welcome back to the Orthopedic Tutor channel. Today we'll be talking about the adolescent idiopathic scoliosis. And because this is such a huge topic with a very wide coverage, I'm going to divide it into two parts. In this first part of the video, we'll discuss about the basics, which includes the epidemiology, definition, etiology, classification, and also some part of the diagnostic process, which includes the history taking, physical findings, and additional examination. As for the curve progression, management plan, and more on the AIS, we will discuss it in the second part of this video. And now let's get it on with the first part, which is epidemiology. Usually, the onset of disease, we call it adolescent because we find it usually after the age of around 10 years old. More commonly found in the female population, with right thoracic curve as being the most common curve. Now, this condition may be related to positive family history and also various factors such as hormonal factors, the level of melatonin, the brainstem proprioception, and other platelet problems. Now, per definition, this condition or adult idiopathic scoliosis is a scoliosis or a spinal curvature that occur in the adolescent age population, and also the cause of which has not been identified before. Now, there are various types of scoliotic curves that you need to be aware of, and we will use it a lot in our further discussion. We call it the compensatory curve when the secondary curve is located above or below the main curve, so it actually compensates for your curve. And we call it a primary curve if this is the earliest curve that is present, and we call it a structural curve when the segment of the spine has a fixed lateral curvature. Now, other definitions or terms that will be frequently used are the stable vertebrae, which is the most proximal vertebrae that is most closely bisected by the CSVL or the central sacral vertebral line. So this is the central sacrum vertebral line, and the vertebrae that is most closely bisected by this line is called the stable vertebrae. Now, the second term is the end vertebrae, which is the most tilted vertebrae, and the end vertebrae and the neutral vertebrae is the one that has no rotation in the axial plane. Now, the apical vertebrae is the vertebrae that is deviated farthest from the center of the vertebral column. With this would be called as the apical vertebrae because it is deviated farthest, and this would be called as the end vertebrae because these vertebrae are the ones that started the curve, and the curve is bounded by these two vertebrae. We call them the proximal end vertebrae and also the distal end vertebrae. Now, to identify this vertebrae, you could always evaluate the width of the disc space. We will discuss about it later on with an example of the radiograph. Now, the next thing you need to do is to know what causes it, which is unknown. That's why it is called an idiopathic condition. Now, the classification scheme can be divided into several classifications. The old ones would include the king-moe classification, which classified into 5 types based on the generally how the curve looks. Now, for the type 1, the curve has a S shape or double curve in which both the thoracic and also the lumbar curve, they both cross the midline. Now, the second curve would also be an S curve in which both the thoracic and the lumbar also cross the midline, but in this case, the thoracic curve is larger and stiffer compared to the lumbar curve, while on the type 1, the lumbar curve is larger and stiffer than the thoracic curve. For the third type of the king-moe classification, you would see that the thoracic curve crosses the midline, but the lumbar curve does not cross the midline. Next would be the fourth and the fifth type. You could see here that on the fourth type, there would be a long thoracic curve in which the L5 here is still centered over the sacrum, but the L4 already tilts along into the thoracic curve. Now, for the type 5, this is a thoracic curve, especially the upper thoracic curve, but you could also see that the T1 is also involved. It tilts over to the upper curve. Now, the more commonly used classification scheme nowadays is the Lenke classification, and you can divide it into 6 types of curve, and you need to know or get yourself familiar to these basic terms. I'm going to show you this table here, the classification scheme, and you could see here that the curve can be divided into 6 types. We call it the 6 curve types of the Lenke classification system. And first, you need to identify where is the structural curve and the non-structural curve. It could be situated over at the proximal thoracic region, main thoracic region, or the thoracolumbar or lumbar region. So back to the first point, you need to determine what is the structural curve, and then what is the non-structural curve. And next, you need to plot them inside this table based on the location of the curve. Is it at the proximal thoracic? Is it at the main thoracic, or at the thoracolumbar or lumbar region? The next thing you need to know is you need to measure what are the criteria for the minor criteria for the structural criteria. The criteria includes side bending curve of more than 25 degrees and kyphosis from the lateral view. Now, afterwards, you need to identify the modifiers which can be determined, which could be classified into 3 types of lumbar modifier A, B, or C based on the CSVL line to the lumbar apex. If the line here crosses in between the pedicles, we call it lumbar modifier A. If it touches the apical body, we call it B. And if the whole apex is completely away from the midline, we call it C. The last thing you need to measure is the thoracic sagittal profile. This is taken from the lateral view. You measure the kyphosis starting from T5 to T12, and you could determine whether or not this is a hypokyphosis, normally kyphosis, or hyperkyphosis. Now, the classification is then written as such. First is the number, the curve 1 to 6, and next would be the lumbar coronal modifier A, B, or C. As shown here in the example, this is a 1B, and then if you find a hyperkyphosis curve, then you put a plus in it. So as a whole, a complete classification would be written as 1B plus. Now let's go back once again. The curve should be determined as a structural curve or non-structural curve first. You define a structural curve as the one that has the largest curve or the largest cup angle. Now, when you see a X-ray and the patient's spine is bended in such ways that resemble an S shape, there is usually 2 curves going on there, and the largest curve is always determined as the structural curve. If the curve has an apex that is located at T3, 4, or 5, you call it a proximal thoracic curve. If the apex is over at the T6 to the T2, 11 or 12 disc, you call it as a main thoracic curve. If the apex is over at the thoracolumbar region, then you call it the apex should be around T12 to L1, and if the apex is over at the L1 to disc to L4, we call it a lumbar curve. So once again, when you look at this table and you have measured all those curves that is going on in your patient, and you find the largest number is at the main thoracic region with the apex going on around the T6 and T12 here, T6 and T12, T11 or 12 disc, then you would say that this is a curve type 1. Now, what if you have a second curve? Then that second curve should be known as a non-structural curve or a minor curve. Now, we define it as a curve if we find that during the examination, even though the side bending curve is more than 25, you could also evaluate it from the kyphosis. So sometimes you can find a minor curve being so small, but when you take a lateral radiograph of that minor curve, you find it to have a huge kyphosis. Now, when you do that and you find a kyphosis degree that is over 20 degree, then you can still count it as a minor curve. Now, once again, I'm going to go over. The largest curve is the structural curve, and the curve that is smaller than the structural curve is the non-structural curve. Now, you say that it is a structural curve when it is the largest, or when you do a side bending radiograph. We'll discuss about it later at the end of this video. At the side bending radiograph, the curve fails to bend to less than 25 degree, meaning that when the patient has bent towards the curve, when you measure the cup angle once again, it shows a number that is more than 25 degree. The next evaluation in Lenke is that you need to know where is the side of the curve. You call it a thoracic curve when the curve is over at the T2 to T11 or 12 disc. We call it a thoracolumbar curve if the curve is around the T12 L1, and lumbar curve if the curve is around the L1 disc, 2 disc to L4. Now, there are 6 types based on these curves, which is shown at the previous table. Now, these are the lumbar modifiers, which is the A, B, C. A when it falls between the vertebrae, B if it touches the in between the pedicle and lateral, and C if it touches or is outside the apical vertebral body, with 3 types of thoracic modifiers, which could be hypo, normal, or hyper. You measure this from the lateral radiograph. This is once again a picture showing the lumbar modifier A. B, you see it goes a little bit to the almost nearly out of the vertebral body, and C if it goes out of the vertebral body. Now, this is also a picture here that shows you the lumbar spine modifier ABC rules. It has been mentioned that if you find that there is a pelvic obliquity of less than 2 cm, then it is okay. But if you see a pelvic obliquity of more than 2 cm, you must place a block on the shortened leg so that when the patient stands up, the pelvic reaches an equal height. Now, next is what you do to aid your diagnosis, which is history taking should reveal that the patient is asymptomatic. The physical findings is more significant on what you see. Now, the things that you could find includes cafe au lait spots, midline skin deficits, such as hairy patches or any dimples. You should also evaluate for any shoulder elevation while the patient stands up like this. You should see how is the shoulder height, and then you go down to see any shift of the trunk. You could see the trunk that has shifted to the right side here, and then you could see for any waistline asymmetry. You could see for any limb length inequality, any rotational deformity at the rib, and a prominent scapula. Now, for me, I would generally do a physical examination from top to bottom to make sure I do not miss anything. So anything that goes from top to bottom is evaluated systematically, from the shoulder down to the rib hump, to the prominent scapula, to the shift of the trunk. You could also see here the distance between the waist and the arm that is unequal on the left and the right sided. You could see the waistline asymmetry and also the pelvic obliquity. Now, the things you could do to evaluate the neurologic findings. I'm going to show you this one test first. This is called the Adams forward bending test, in which the patient is asked to bend forward, and you as the examiner examine the patient from the posterior aspect. Now, you could see here that one side of the back shall appear higher than the other. This is due to the rotation of the rib cage itself. So this is the prominent rib bones. Now, the next thing you should do is evaluate whether or not there is any abnormal neurologic findings. Because the lesion itself is located mostly at the thoracic or the lumbar region, you could find that if there is any abnormal signs, it should include asymmetric abdominal reflex. We could see here that this is an example of a patient undergoing this examination. The abdominal reflex exam is performed with patient supine. This blunt end of the handle of this reflex hammer is used to stroke the skin here in each quadrant, 1, 2, 3, 4, each quadrant with a distance of around 10 centimeter. Now, the asymmetry of the reflex is shown when there is asymmetrical movement of this umbilicus around the area of the stroke. Now, this should reveal then there is an abnormal neurological finding, and you should do MRI in this patient. And for the spine balance, there is several spine balance that need to be evaluated, and that includes the coronal balance, trunk balance, and also the sagittal balance. Now, for the coronal balance, you could evaluate it using this type of measurement. You take a simple line here, a measuring tape. Usually you put away over there, and you place it over at the spinous process of the C7, and this line at the end of it, it should lie directly over at the central of the gluteal fold, also known as the central sacral line, and it should not deviate to the right or to the left no more than 1 to 2 centimeter. Now this is the another depiction here where the line is being placed and being pulled down, and it should not deviate laterally more than 1 to 2 centimeter. The next would be the trunk balance. You could see here that a measurement is being taken for trunk balance. So two vertical lines are drawn on the radiograph. First would be the line that is the center of the sacral line, which is here, or the black line here. The next line is the vertical line that bisects the horizontal line drawn from the peripheral edges of this rib cage. So you draw a line here at the widest portion, and you take the mid portion of it and you draw a line down here. Now the distance between these two lines quantifies the amount of the trunk imbalance that the patient has, or as depicted here as a purple color. You can see it here. Now this is another measurement of the trunk balance that is being remeasured after the patient had underwent surgery. So once again, the pink line here is the vertical line or the central sacral line. The second one is the green line is the line that bisects the peripheral edge of the ribs, and the distance between it, this is the trunk balance. Now the next thing you could do is measure the sagittal balance. So from when you measure a sagittal balance for the patient, when you draw a line from the center of the C7 of the vertebrae, you evaluate it and in relation to the posterior superior edge of the S1. Normally it should lie around 2.5 centimeter. And once again, this is taken from a lateral whole spine radiograph. If you call it a positive sagittal balance when this line lies anterior to the L5-S1D space, and you call it a negative sagittal balance if it lies posterior to the L5-S1D space. For more discussion regarding this sagittal balance, you could check out my spondylolisthesis video, the part 1 video. I have an extensive discussion regarding sagittal balance there. Now, moving on, the additional examination that you could do includes the most basic and most important view, which is the plane radiograph. Now, for the plane radiograph, you should take it, the radiograph should be taken for the whole spine, or also known as a full length posterior, anterior, and lateral radiographs of the spine. You take it with a 36-inch film, and you should have the patient place their hand such as these to avoid the superposition of the image of the humerus along with the spine. And next, you could do another radiographic evaluation of these radiographs that you have done using the COP method to measure the angle of the spine, and you could also determine the Risa sign from the pelvic radiograph. You could also assess for the overall balance and also any congenital abnormality that may be found. From the lateral radiograph, you could find from the thoracic it could be a hypokyphosis or a hyperkyphosis condition. Now for the lumbar view itself, you could evaluate for the evidence of any hypolordosis or even spondylolisthesis of the L5S1 due to the disruption of the sagittal balance. Now, for the MRI itself, it is only indicated in certain conditions, such as if you find a left thoracic curve, you find a painful scoliosis, you find a scoliosis with rapid progression of the angle, or you find a apical kyphosis of the thoracic curve. It could also be from a juvenile scoliosis. If you find it, you could do an MRI to evaluate it furthermore. You could also do MRI when you see any neurologic symptom abnormalities or to identify any cyst or syringe. And I skipped this, sorry. This is one of the tools that you could use to evaluate patients with scoliosis. It is called a scoliometer, and you could see here this little bead that is embedded within the tools. It is also known as the inclinometer, and you could use it to measure the angle of vertebrae rotation. Usually you use it to evaluate the paravertebral muscle asymmetry that occurs. So in the thoracic spine region, you use it to evaluate for rib asymmetry. Once again, in the lumbar region, you use it to evaluate for the paravertebral muscle asymmetry. For the thoracic region, you use it to evaluate the rib asymmetry. Now, I guess that would be all, but before I end this video, I would like to show you this picture here on how to evaluate for the cup angle. As I zoom in here, sorry, the picture is not quite good, but yes, you could see it here. You can see that the curve is clearly situated over at the thoracic region. But the question is, I've been talking about the angle all the way, and how do you make an accurate measurement of these angles? Now, if you pay a close attention here, as the curve progresses to the right, let's say this is the right side, which is the R here, and these are the left side. So as the curve progresses to the right, you could see that this angle here, it is slightly narrower at the right side and opens up at the left side. But until it reaches this structural curve, when it reaches this structural curve, this angle becomes equal. You could see here that on the left side, on the right side, both the disc has the same height. Once again, as this curve turns around to the right side, you could see that this space opens up at the left side and becomes narrow at the right side. But at one point, it shall become the same, either at the left side and the right side. And then as it forms this main curve and as it turns toward the left side, you could see once again at the left side it becomes narrow, and at the right side it opens up. Now this is determined as the end vertebrae, or the point where the vertebrae forms the whole curve. So you pull a line over at the lower part of this vertebrae here as your first guiding line, and then you find the vertebrae with the same criteria, which should be around this vertebrae. You pull another line from the superior aspect of the vertebral body, and the angle formed by these two lines, this one up here and this one down here, that is your curve magnitude, or also known as the Cobb angle. Now, you need to do a lot of practice to make sure that you can identify the vertebrae correctly, and you also need to have it noted down in your medical records so that you measure the same vertebrae next time you do an evaluation of your patient. We'll discuss more about that on the second part of this video regarding adolescent idiopathic scoliosis curve progression and also comprehensive management plan. Thank you for watching and be sure to subscribe to the Orthopedic Tutor channel for more videos. See you.